Thanks for joining us on day 2 of this conference. We're excited to start the day with a more challenging and complex session where I anticipate we'll only really scratch the surface on trying to understand fatigue and fatigability in SMA and DMD. Fatigue is a broad term that's used to describe several different experiences and observations. There was a helpful taxonomy published in 2013 to define fatigue in neurological diseases, so I'd first like to start with some core definitions. There are 2 main categories: perceived fatigue, in which is a person's subjective report of feeling an overwhelming sense of tiredness, increasing sense of effort, lack of energy and motivation, and a feeling of exhaustion, mental, physical, or both. Physiologic or physical fatigue is also known as fatigability, and this is considered work capacity, a decline or a decrement in one or more aspects of performance with a continuous or a prolonged task. Perceived fatigue can be quantified with patient-reported outcome measures requiring recall of the perceived functional impact of an experienced fatigue on the ability to perform cognitive, physical, or psychosocial tasks. Whereas fatigability can be estimated as perceived fatigability or quantified through performance, objective fatigability. It's important to distinguish between these two because there can be different underlying factors, including psychological and physiological components. Perceived fatigue and fatigability are not only different, but potentially independent of one another. And understanding this relationship has been a key objective for clinical research, but has proven challenging for most disorders. And we have found that they are not related to each other in SMA and therefore should be treated separately. So for the rest of my talk, I'm going to provide a framework to try to both understand and organize the dimensions of fatigue while considering the challenges and opportunities in these diseases. And to provide an overview of what we'll try to uncover for the other presentations, we'll look at exercise-induced fatigue and fatigability with Tanya Tavasalo, assessing fatigability with Bart Bartels, and looking at applications to address fatigue and fatigability with Mariska Jansen. So we know fatigue is a common symptom in SMA. It's widely known to be one of the most disabling symptoms and has a prevalence reported of between 81 and 100%. There was a Cure SMA community online survey assessing health-related quality of life, loss of work productivity, and fatigue in 2019, and all affected individuals with SMA reported higher fatigue levels than those in the general population that you can see here in pink in the figure, using the PROMIS fatigue short form. And these T-scores allowed for a relevant comparison across all groups with the overall US population. You can see that all the scores were worse than the average general population score of 50, but there did not appear to be a trend of scores increasing or decreasing by SMA type, functional status, or permanent ventilation. Other reports have shown prominent fatigability in those with and without preserved muscle strength and function. And despite treatment, it remains a burdensome and challenging manifestation of SMA. So I'd first like to start showing you an illustration of what performance fatigability looks like in SMA. Here we have a video of a little boy, a 3.5-year-old boy, performing the 6-minute walk test. This first video is of him in his first minute. Thankfully, the family allowed us to have him underdressed so that we could see the mechanics of his body. But you can see he has a typical wide adapted gait, large arm swing, but he's doing pretty good, chugging along this first minute, and at 3.5-year-old, he's understanding the test pretty well. Sorry. Here you'll see in the 3rd minute, he is stopping and resting. The fatigability is starting to set in. With this test, we're advising them to take breaks as needed. So you can see he has a little bit of postural adaptations, maybe a little bit of loss of balance there. He's not able to necessarily walk as straight of a line as he was before. So to us as physical therapists, we're seeing that he is definitely starting to look a little bit more tired, actually experiences a bit of a fall there, but we're able to catch him safely. And then here in the 6th minute, you'll see that it's his fatigability is definitely increasing. He is walking slower. He's taking many more breaks. He's really trying to give his best effort. He's doing a great job, and also just doing a great job of understanding the task that we're wanting him to walk as far as he can in 6 minutes. But you can see the breaks are more frequent. He's leaning onto the table, and so this is a tiring test for him. But just a great example of what performance fatigability looks like in an ambulatory patient. Now I'm going to switch over to fatigue in DMD, and it's not as highly reported, with approximately 40% of individuals experiencing symptoms. The literature remains limited. However, fatigue has been shown to be related to overall quality of life, particularly in the physical health and environmental domains in adults with DMD. Fatigue levels and energy expenditure have been shown to be higher than healthy peers. Greater fatigue has been associated with sleep disturbance, depressive symptoms, and lower functionability. However, fatigue is not associated with physical activity level and musculoskeletal, respiratory, and cardiac function. And I think this just highlights that it's a complex topic, and understanding the relationship of perceived fatigue with perceived function, respiratory, and cardiac function is challenging. Most recently published this year, there was data published from the phase 2b double-blind randomized placebo-controlled trial of ataluren, where they were evaluating health-related quality of life and perceived fatigue in boys 5 to 16 years old. To predict fatigue trajectories, they used latent class growth modeling analyses where they can to determine patterns of fatigue using the PEDS-QUAL multidimensional fatigue scale over a 48-week period, classifying the patients into distinctive trajectory groups. So here in this top figure, this is showing the trajectories of the self-reported fatigue scores. Here, a higher score actually responds to decreasing level of fatigue. So you'll see here in the moderate fatigue group in blue that the scores remain stable over the 48-week period, but in the high fatigue group score, this is in red, it slightly decreased over the first 24 weeks, but then slightly increased, while the lower fatigue group score in green increased over time and was significantly corresponding to a decrease in fatigue level. Those in the low fatigue trajectory tended to be younger and have higher 6-minute walk test distances. This bottom one is now the parent proxy report of fatigue scores, and both the high and moderate fatigue groups, blue and red, those scores remain stable over the 48-week period, while the low fatigue group scores increased over time, leading to a decreasing fatigue level. So in this study, they found that baseline fatigue was found to predict baseline quality of life while controlling for age and 6-minute walk test distance. They found that change in fatigue over a year was correlated with age and functional ability as measured by the 10-meter walk-run test. And for each 1-year increase in age, this was associated with a 24% increase in odds of being in the high fatigue trajectory group. And they found that age, baseline 6-minute walk test distance, and steroid use were significantly associated with the risk of belonging to the high fatigue trajectory group. Therefore, a greater understanding of fatigue is now in demand. In this era of genetic treatments, we need to better study the complexities of fatigue and comprehend the real-life impact of these interventions on perceived and performance-based assessments in these diseases. Fatigue is complex and multidimensional, and this figure represents a framework of the different dimensions of fatigue most commonly studied in SMA research, included here in yellow. So you'll see sleep-rest fatigue, motivational fatigue, mental fatigue, cognitive fatigue, general fatigue, as well as physical fatigue. In purple, we have constructs related to physical fatigue dimension, which are assessed by some patient-reported outcomes. And in light blue and gray, you'll see attributes of physical fatigue. Performance fatigability is light blue, and perceived fatigability is gray. The two-way arrows represent relationships. They provide a theoretical framework for conceptualizing physical fatigue, performance fatigability, and perceived fatigue, as these are interrelated concepts that likely interact and influence each other during physical activity. And in green, you'll see here the fatigue confounders. So strong associations of perceived fatigue and performance fatigability have been difficult to establish in SMA. The multidimensionality of patient-reported fatigue is reflected in patient-reported outcome measures applied to SMA. And here in red are the patient-reported outcomes that include items categorized into these multiple dimensions of fatigue. All patient-reported outcomes demonstrate fatigue as an intractable symptom, emphasizing that it's a component of the disease that we should better aim to understand. Now, with our focus more on the physical fatigue dimension, this is proposed to be the most relevant to SMA pathophysiology given their muscle weakness and their decreased exercise capacity. These constructs related to the physical fatigue dimension include causes of fatigue, perceived exertion, the impact on function, intensity of fatigue, consequences of fatigue, and other related components like sleepiness and tiredness. However, conflicting terminology has made the assessments of physical fatigue challenging. As I mentioned at the start of the talk, fatigability is defined as the susceptibility to fatigue or work capacity, and it can be estimated using patient report or quantified. However, when you're looking at the intensity of fatigue or severity and using a scale like the visual analog scale, this is really not a measurement of fatigability. Same goes for looking at perceived exertion and using a scale such as rate of perceived exertion. This is really effort and not a measure of performance fatigability. And same goes for tiredness and the other constructs here. When examining the attributes of physical fatigue, we have performance fatigability and perceived fatigability. Performance fatigability, as I mentioned before, is an objective measure of the decrement in performance with a repeated task. It's the opposite of endurance and a characteristic of the SMA experience. In SMA, performance fatigability and diminished endurance have been demonstrated with the use of these validated performance-based assessments, and Dr. Bartels will highlight these assessments in greater detail in his talk. Previous work has proposed that the disabling fatigability in SMA may be caused by activity-dependent conduction block caused by collateral sprouting. Others have shown that neuromuscular junction dysfunction caused by maturation and developmental abnormalities due to estrogen insufficiency. And most recently, the role of mitochondrial dysfunction and its impact on reduced exercise capacity has been demonstrated. I do want to highlight the body of work from the PNCR network in the US that first investigated the utility of the 6-minute walk test and found that the 6-minute walk test can capture fatigability in ambulatory SMA patients, which I think you saw in our illustration of our video. We found that the velocity in the first minute was significantly faster than the velocity in the 6th minute, and that this difference represented a 17% decrement in performance. We then wondered what was contributing to this change in velocity. Was it changes in stride length or cadence or both? And to better understand that, we incorporated gait analyses and found that the changes in velocity were determined by changes in stride length, not cadence, and that this did not occur in healthy controls. We then wondered what changes were contributing to this decrease in stride length and if there was a relationship to the typical patterns of weakness that we see in SMA. So we incorporated surface EMG to evaluate the muscle function of the quadriceps, the hamstrings, the anterior tibialis, and the gastroc muscles during the 6-minute walk test. And consistent with previous findings, we observed decreases in stride length and EMG amplitude of these key muscle groups, which confirmed fatigability during the 6-minute walk test. Another attribute of physical fatigue is perceived physical fatigability. This is a whole body measurement of one's susceptibility to fatigue with physical activity of a fixed intensity and duration. Anchoring the activity to a fixed intensity and duration offers a standardized approach to measuring the degree to which fatigue limits physical function. This concept of perceived physical fatigability allows for variability in responses, which is useful when you're trying to discriminate capacities between patients in this broad phenotypes. And currently applied patient-reported outcome measures are limited in their ability to capture specific stimuli that are required to induce these varying levels of perceived fatigability in SMA. So as expected, there's a lot of challenges when trying to understand the complexities of fatigue and fatigability in SMA and Duchenne. The confounders of patient-reported fatigue in SMA have been reported to include sociodemographic factors such as feeling increased perceived fatigue for those that are unemployed or those with less than 12 years of education or have symptoms of depression and anxiety. Other psychological factors that need to be considered is task familiarity, patient temperament, and motivation. And then other fatigue-related phenomena that need to be considered or that may play a role is sleepiness, tiredness, and apathy. As I mentioned before, there's a consistent absence of association between patient-reported fatigue with available functional measures. And so this is really making it challenging that perceived fatigue is not necessarily an adequate reflection of functional status. And lastly, there are several metabolic, hormonal, and signaling pathway stimuli that may induce the sensation of muscle fatigue both centrally and peripherally. And I think that'll be touched upon later by upcoming speakers and may impact a patient's fatigue perceptions, which just adds to this complexity. There are opportunities, however, in that we believe that in this era of genetic treatments, learning about the mechanisms of fatigue will be extremely valuable when trying to understand the impact of treatment, and having complementary outcome measures other than motor assessments are going to be necessary. So there is a possibility that an individual's perception of fatigability may be more sensitive to change than performance fatigability measures, which are limited in application. Excuse me. The capacity of the patient is a limiting factor where you can only administer the 6-minute walk test in someone who's ambulatory, and so this provides an opportunity for us to try and characterize fatigue and fatigability across everyone. So therefore, it may be increasingly valuable to measure perceived fatigability's real-life impact and encourage a step towards better understanding this attribute of physical fatigue. And a patient-reported outcome measure that anchors activities to intensity and duration can be useful in understanding an individual's vulnerability to perceived fatigability. And so we embarked on a journey to develop a perceived physical fatigability scale with the aim to be SMA-specific, novel, and a patient-reported outcome to standardize the assessment for those 12 years and older. It's called the SMA Effort Experienced Fatigability Rating Tool. Our methods included developing a preliminary item bank of 108 items where we identified tasks that were most reflective of physical fatigue in SMA, and our item pool was intentionally broad so that we can encompass the broad phenotypic spectrum of SMA, looking from non-sitters to walkers. You can see here in this figure some of the subdomains of being self-care, sedentary activities, lifestyle or light intensity activities, and moderate high intensity activities with some examples that include intensity and duration anchors. Our questionnaire asked the participant, have you completed this activity in the past 30 days, yes or no? And if yes, they were asked to rate the level of perceived fatigability with attention to the intensity and duration. They responded on this response scale of 0 being no fatigability and 5 being severe fatigability. We learned through this experience, though, that if the participant had not performed the activity in the past 30 days but had performed it in the past, we were really relying on patient recall, and this was extremely difficult to interpret, and we weren't sure how meaningful that was for us or the patient experience, so those responses ended up being removed. So our patient pilot data collection included 118 surveys. This was all administered on REDCap, open access, and our mean age was 41 years old with a range of 14 to 78. You can see in this pie chart that the majority were sitters, 45%, non-sitters, 40%, and 15% were walkers. Nearly half were male, 61% were on a disease-modifying therapy, and this was the survey was distributed by Cure SMA and through the International SMA Consortium with people answering from the US, Italy, and the UK. So as not all participants responded to the same activities given the varying levels of functional abilities, we established a perceived physical fatigability score that could be applied across all patients. Using this score, we found that there was no association with age, no differences with disease-modifying therapy, and a varied response within and between functional groups. Now, we did not inquire which disease-modifying therapy they were on or for how long, but we find it interesting and helpful that perceived fatigability linked to different activities that are anchored to these different intensities and durations can really reflect the broad experience patients encounter despite having these different levels of abilities. So our next steps include scale refinement and using item response theory to identify the most relevant items, the most relevant times durations and intensities that felt reflective of the SMA perceived physical fatigability experience, and also as well as eliminate redundant items. We will be piloting a validation study, and with the implementation of a perceived physical fatigability scale like the SMA effort in combination with motor function testing, physiological measures, and potentially treatment, we believe that this will be able to characterize fatigability. So I'll end here with saying that although fatigue is complex in understanding the framework for the dimensions, the constructs, the attributes, and the confounders, this is really important for us to learn from. And we know fatigue is a problem in SMA and DMD. We know that the pathophysiology is multifaceted. We have some understanding of the mechanisms that include fatigability, such as the neuromuscular junction or mitochondrial dysfunction or metabolic impairments, but we don't understand the relative contributions of each of these purported variables to the problem. And our ability to improve assessments of fatigue and fatigability can lead to better treatment. So I'd like to acknowledge for this talk our review paper measuring fatigue and fatigability in SMA that was published earlier this year in the Journal of Clinical Medicine and was led by first and senior authors Rafael Rodriguez-Torres and Jacqueline Montez. I'd also like to acknowledge the collaboration with the University of Pittsburgh with Nancy Glenn and colleagues. They developed the Pittsburgh Fatigability Scale for older adults, so this really supported our approach to develop a disease-specific scale. And then lastly, I'd like to acknowledge the International SMA Consortium collaborators with the PNCR, the Italian SMA Network, and SMA Reach UK, and that this work was supported by Cure SMA and Neuromuscular Study Group. And that's it. Thank you. So the question is, are the different elements of perceived or performance fatigue or fatigability you defined all distinct, separable, and independent? Or are they inevitably linked and interdependent? It's a great question. I probably, and I would love to hear Tanya's response here as well, probably believe they're linked and interdependent. There's no way that they could probably be separable and distinct, and I just think it really adds to the complexity of trying to wrap our heads around this topic. And I can say that we had many conversations about just how hard putting this presentation together was, or putting this session together was, because the linking and the interconnectedness is really just very complex. I see that there is one more as well. Is perceived and performance fatigue or fatigability affect each other? Do treatments need to address both perceived and performance to be effective? I think this is also a great question. Yeah, I think if we could definitely learn more from our current treatments that are available and evaluating if the experiences of, well, we do know a little bit about performance fatigability with some of the treatments that are currently available, but there's limited reports out there of what perceived fatigue the patient's experience is on currently treated patients. So I think something like the addition of the perceived physical fatigability scale that I mentioned at the end might be able to actually reflect the patient experience better of fatigability, and anchoring to intensity and duration will really allow us to look at the impact of treatment, I think, a little bit better and more focused than what is currently available. So we didn't ask too many more questions than what you saw. We really just kind of got the bare demographic information, because again, this was more to look at are the items relevant to the SMA experience. But the fact that there were no correlations to age or disease-modifying therapies or within the functional status, I think that's a good thing that there were no correlations. It's really just saying that someone who is a non-sitter with SMA and has very limited functional ability is experiencing perceived physical fatigability in their life to potentially the same degree as someone who's walking. And this is something that hopefully we can be able to capture and measure and quantify using the same scale.
That was really excellent. And in clinic, we're always trying to find something we can do to tweak to improve fatigue for our patients, even if it's a little factor. And I was interested when you mentioned the Duchenne part of the data that steroids were a factor. Was that an inverse relationship, or use of steroids correlated with more fatigue? I didn't catch that.
Yeah, I believe that was an inverse relationship. Yeah.
And then I was wondering with the SMA survey, I don't know if it was collected or not because it's a survey, but we always, look at things like need for non-invasive ventilation, being able to utilize non-invasive ventilation if it's been recommended, body mass index, either low or high. Were there any correlations with those, or is that we need some more follow-up data?
Yes, we definitely need more follow-up data for that as well. Yeah.
Give an overview of what I found to be a very complex topic. And I'm going to give this overview through the lens of an exercise physiologist, which is what I consider myself more. And we'll talk about the contributions of skeletal muscle impairment to exercise-induced fatigue and fatigability. So we know that, once I just advance my slide, that patients with neuromuscular diseases, pretty much all patients with neuromuscular disease experience fatigue, fatigability, muscle weakness, exercise intolerance to varying degrees, and that really relates to the underlying etiology of their disease. So if there's a deterioration in the anterior motor neurons, of course, we have spinal muscular atrophy. We can get impairments in the peripheral nerve, leading to Charcot-Marie tooth, impairments at the neuromuscular junction with the congenital myasthenic syndromes, or impairments within the skeletal muscle itself. So those could be structural, which we see in the muscular dystrophies, or metabolic, which we of course have with the mitochondrial diseases and glycolytic disorders. So today the focus is on SMA and DMD, and I'm going to try to kind of compare and contrast what we know about fatigue, what we know about fatigability, which again, as Sally nicely defined, is the inability to continue exercise at the same intensity. And when we're talking about fatigability, particularly in clinical conditions, we typically assess fatigability during submaximal exercise. But I also wanted to bring up the concept or notion of peak aerobic capacity, which is defined as the amount of oxygen consumed during maximal intensity exercise. And this is a really important index or outcome of cardiorespiratory fitness. It's a predictor of exercise capacity that is necessary for doing activities of daily living, of living independently, and it's an indicator or predictor of morbidity and mortality. So we feel that measuring peak exercise capacity or aerobic capacity can also be really informative when trying to understand fatigability and particularly how to improve fatigability. And another definition is exercise intolerance, which is more vague than fatigability because of the definition that exercise limitations where trivial exertion produces muscle fatigue and lactic acidosis. And this terminology was more used in the metabolic myopathies, but again, I think certainly patients with Duchenne and SMA experience exercise intolerance. Before I really get into the disorders, I wanted to bring us back to the basic level and just remind everyone that the central process of physiological fatigue relates to the ability of the muscle fiber to balance the production of ATP to the utilization of ATP. And that's done through mitochondrial oxidative phosphorylation. So the mitochondria play a pivotal role in maintaining muscle force during exercise. And that's just illustrated in this very basic study. And I say basic because they just microdissected single muscle fibers and measured the force that those muscle fibers produced while being stimulated with tetanic contractions. And what you see on top is a fast twitch muscle compared to a slow twitch muscle, and you'll obviously notice that the time to fatigue is much greater in the slow twitch muscle, about double that of the fast twitch. And then they took those single muscle fibers and did electron microscopy on them to measure mitochondrial volume density. And again, you can clearly see that the slow twitch muscles are much more abundant in mitochondria. And the beauty of this experiment is that it doesn't have any influence of blood flow, substrate utilization, or muscle fiber recruitment because they're isolated fibers. And so this really beautifully demonstrates that at a single muscle fiber, myofiber basis, mitochondrial oxidative capacity is a major determinant of muscle fatigue resistance. And so that is something just to keep in mind as we go through and talk about mechanism, as was asked earlier. All right, so I won't really talk very in detail about fatigability and SMA, as you all know about this. It can be measured both during the 6-minute walk test, as is shown, but also during cycling, where we can look at the difference in either distance walked or the workload in the last minute of the exercise test versus the first minute. And as you can see here on the right-hand side, the healthy controls that do this submaximal test exhibit no fatigue, whereas patients that have SMA show really remarkable fatigue with this type of protocol. And if we think about the pathophysiology of that fatigability, this is a study done by Jackie Montez and colleagues where they used near-infrared spectroscopy. This is a non-invasive approach that indirectly measures muscle oxygen uptake. And so basically what it does is it measures the amount of oxygenated hemoglobin and deoxygenated hemoglobin, and that difference reflects the amount of oxygen that was extracted and utilized by the muscle mitochondria. So if we look at the data here, this is showing the change in the deoxygenated signal, which reflects muscle oxygen uptake. On the left-hand side are data from the submaximal exercise testing. In the controls, you can see as you go from rest to exercise, there's an increase in that deoxygenated signal, and it's a greater increase during peak exercise, which makes sense. And what is notable here is that in these patients with SMA, this increase is really blunted or non-existent during exercise. So this just suggests that the skeletal muscle in SMA is not able to increase extraction of available oxygen. And this is a very similar situation to what we see in patients with primary mitochondrial myopathy. It's a different patient population that has severe exercise intolerance due to mutations in mitochondrial DNA. And what we know about these patients are that they are not able to increase oxygen extraction either. And so last night I just went through some data that I had from years ago that still needs to be published while I was with Ron Haller. And we just did a submaximal cycling test at 50% of their peak work capacity, and we had them do 30 minutes. And again, these are patients with severe exercise intolerance. And the blue dots here just represent healthy controls, and the triangles are the mitochondrial patients. At baseline, we then exercise train them, but I'm just focusing on the baseline time point to show that with 30 minutes of this submaximal exercise, there's very little drift or increase in heart rate. But we do see some increase in the Borg scale of perceived exertion, which again, I appreciate is not really fatigue, but their perception of exertion. But the point I want to make is that the mitochondrial disease patients really have a similar response to the healthy controls. And these are, again, patients that have a severe deficit in mitochondrial ATP production. And again, I just point this out to emphasize the fact that with SMA, they have mitochondrial dysfunction, but their fatigue must come from things other than skeletal muscle mitochondrial impairment. Okay, so speaking of that, to mechanism, these are just some examples taken from a paper which took muscle biopsies from patients with SMA. And again, it's very clear that there is impairment in the mitochondrial respiratory chain components. We see a lot of these cytochrome oxidase deficient fibers in the SMA patients. There's a depletion of mitochondrial DNA and a downregulation of these biogenic factors, which are really important in inducing mitochondrial biogenesis and proliferation, which is necessary during muscle growth and development, during neuromuscular junction formation, during exercise training. So this downregulation of mitochondrial biogenesis plays a role in some of the fatigability that has been seen. And I don't have time to get into the preclinical studies, but there's evidence too that this altered mitochondrial function is not only in skeletal muscle, but it's also in motor neurons, and that may again influence the formation of neuromuscular junctions and impairing synaptic transmission. Okay, so what do we know about the ability of this fatigability to be modulated with interventions? So this is a study showing the impact of aerobic training. And we know it's been well established that aerobic training has benefits. It induces adaptations that improve muscle function, peak work capacity, peak aerobic capacity, and it improves the perception of fatigue. But in patients with SMA that underwent 6 months of aerobic training using these very standard clinical exercise prescription guidelines. What was noted was that there was an increase in peak work and aerobic capacity, but this increase was really blunted compared to what you would expect to see in that time period. We would expect to see at least a 20% improvement in peak VO2, and I think it was between 6 and 10% that was reported. And also notably, only about half of the patients studied could actually complete or achieve that target exercise volume. The other half had to reduce the amount of exercise that they did. And this exercise training did not impact their perceptions of fatigue or quality of life using various questionnaires in both adults and patients. So another study was done by John Vissing's group in Denmark, where they used a higher intensity aerobic training paradigm, thinking that that might get a bigger increase, I guess, in aerobic capacity, which it did. So they worked these patients at heart rate corresponding to 60 to 75% of VO2 max. And what they found was they got this 27% overall increase in aerobic capacity, but this was at the expense of fatigue. So of 8 patients that started the trial, 2 dropped out because of excessive fatigue, and most of the patients had to modify their training, and they couldn't do exactly what the protocol told them to do. And looking at the activities of daily living, there were no cases where they felt that the aerobic training actually improved the level of fatigue. And finally, one other kind of intervention, non-exercise intervention shown here, patients with SMA who received this nusinersen treatment show this over time, a clinically meaningful improvement in 6-minute walk distance, but that was not seen with respect to fatigability. Again, looking at that change in 6-minute versus 1 minute. Clearly there is a need to better understand what is causing the fatigue and then how to mediate or improve fatigue with various interventions. I'll now skip on to DMD. This audience certainly knows the clinical progression and pathophysiology of DMD, where the absence of dystrophin leads to muscle degeneration, excessive inflammation, and other cellular impacts such as vascular impairments, but also notably mitochondrial dysfunction. So when there's a break in the muscle sarcolemma, there's an influx of calcium into the muscle cell. That is then taken up by mitochondria as a buffer, but because it's just an excess amount of calcium, that then triggers something called mitochondrial permeability transition, which just means that the mitochondria basically opens up, releases a bunch of reactive oxygen species, other agents that then cause autophagy, necrosis, and just kind of worsening muscle health. So we know mitochondrial dysfunction plays a role in the pathophysiology of DMD. We know that as the muscles get progressively replaced by fat and fibrotic tissue, that their symptoms of fatigue and weakness progress. And along with that, patients now also limit their daily activity, their daily step counts are lower, and so we have both this kind of mitochondrial pathophysiology and just simple deconditioning that is contributing to this fatigue or fatigability. And if we now look at fatigability, as Sally pointed out, using the 6-minute walk test, here we see no evidence of fatigability during the 6-minute walk if we look at the distance they walked in the last minute versus the first minute. So anything above a 1 would signify fatigue in this case, and the actual average of this fatigue quotient was 1.0. And they had several of these patients they monitored long-term, every 3 to 6 months. And although the distance they walked declined, there still was no apparent consistency in the degree of fatigability that was noted. So the authors concluded that exercise-induced fatigability does not play a relevant role in DMD, and analysis of fatigue is not a useful outcome parameter. One could argue just that maybe the 6-minute walk test is not showing the fatigue, because clearly boys with DMD have fatigability. What about another modality? This is the study done in Holland using the assisted 6-minute cycle test. Here, the idea again was to try to incorporate and get some non-ambulatory boys assessed, and the ergometer was motor assisted, so there was no load for the boys to cycle against. They were just instructed to cycle as fast as you can for 6 minutes. And if we look at the data here, this is using the legs, and on the bottom is the arms in terms of number of revolutions completed in that 6 minutes. You can see, obviously, the patients are lower overall revolutions, but if we just kind of compare the slope at 5 to 6 minutes versus minute 1 to 2 or 2 to 3, you don't see any real change in that slope, again suggesting there's no real demonstration of fatigability using this test. And if we look at the Omni report, again, this is perceived exertion. They did report DMD boys to perceive the exercise greater than controls. But again, I want to point out that this difference was not huge, and they also started out at a higher Omni rating than the controls. So the point being, again, that fatigability is there, but it's not at the same magnitude that we see in SMA. I want to now just talk briefly about some of the work that we're doing and Tina's doing on cardiopulmonary exercise testing to quantify aerobic capacity in these boys. We're using a protocol where boys undergo, this is now non-assisted cycling, so they're using their own muscles. They're cycling at 2-minute stages, and every 2 minutes we increase workload by 5 watts, and they go until volitional exhaustion. And we also can determine whether they actually reached peak criteria for peak exercise based on gas exchange analysis, so looking at whether the RER is above 1.02, whether they achieve a peak heart rate that is 85% or greater of the predicted age max, and looking at their Borg scales. And we get a lot of really valuable information from this test, not only for peak effort, so peak work, peak aerobic capacity, time to exhaustion, but we can also, because we're using 2-minute stages, we're getting some steady state information in that last 30 seconds of each stage that we can now look at some of these submaximal responses, so in cardiac, ventilatory, and muscular responses that I'll show you. Very briefly, these boys are able to achieve maximal exercise. Their aerobic capacity is very limited, and their ventilatory threshold is very limited, which suggests that much of this limitation is coming from the fact that they're relying on anaerobic energy sources to pedal, to power their exercise. But we also see a demonstration of a lower oxygen pulse. This is a reflection of stroke volume, so their stroke volumes are not where they should be. And interestingly, they have a hyperventilatory response, so their ventilation relative to their VO2 is also very high. I'll just briefly say that we're also using phosphorus MR spectroscopy to look at mitochondrial function in skeletal muscle. We can quantify the rate or the time that it takes phosphocreatine to recover, and this is an indirect reflection of mitochondrial oxidative capacity, and boys with DMD have a much slower recovery rate. So we can use this as an outcome as well, but again, showing that this mitochondrial impairment exists. Back to the submaximal exercise responses, what we see here is that as they go along in these work stages, from 10, 20, 30 watts, the VO2 at each stage is much higher than it should be for that level of work. So this shows that they're mechanically really inefficient. They're costing more energy to do this exercise. Their heart rates, their peak heart rates are the same as healthy controls, but again, you'll see that at every work stage, their heart rate is much higher than it needs to be. And this is really a reflection also of deconditioning or a compensatory response potentially for a lower stroke volume to deliver that oxygen and to be able to do that exercise. And oxygen pulse, again, is low. These data are just looking at the ventilatory response. As I mentioned, ventilation is high at each workload relative to controls, and that seems to be driven by a much higher respiratory rate in the DMD boys. So we get a lot of information here, and the point I want to make in case I run out of time is that we can look at whether interventions normalize these responses. So we see that with aerobic training in a pilot study we're doing, these heart rates reduce, the ventilation normalizes. So we may not be assessing fatigability by definition, but we're certainly seeing improvements in their exercise tolerance or their endurance. If I have maybe 4 more minutes, I just want to briefly go over some pilot data of a really exciting study looking at aerobic cycling in these boys with Duchenne. It's a really dear and near project to me because previous studies, only a few studies, 2 or 3 of them have been done, and they've all used a motorized ergometer. So these were important because it showed that these boys can do aerobic training, but we don't know how much work the boys actually did themselves versus what the motor was doing. So we were lucky to get a grant from the Department of Defense, and I worked with some engineers at UF, and we devised a ergometer. It's not very sexy looking, but what it did was it had feedback controllers in the pedals, and this tracked the cadence and really the amount of work the boys were doing. And we were able to adjust the level of assistance that was provided in real time based on their RPEs and based on their heart rate. And so the boys would see this computer screen here, and the yellow line would indicate the target intensity that we wanted them to exercise. And if their actual intensity, which is the blue line, fell below that target, the motor would add a little bit of assistance. But if it went above that yellow line, it would add a little bit of resistance. And doing this, we were able to actually quantify how much work the boys were doing versus what the motor was doing. And we found that these boys could do anywhere from 5, 10, 15 watts. And I'll just really briefly show you. We brought these devices to the boys' homes, and here they are exercising, and they did a great job in staying above target. All right, so I'll skip over this. But I wanted to show you some of the heart rate data. This is just an example in one boy for simplicity to show you that at baseline, he was able to do 6 minutes of exercise. His heart rate reached the upper limit of his training zone at 170 beats per minute. We stopped him, took a break, and then he did another interval session. But if you notice here at 3 and 6 months, he's now not only going longer without stopping, but his heart rate is 15 to 20 beats lower than it was at baseline. And we saw this improvement, this reduction in submaximal heart rate in all of the boys that we trained. And this is really a classical adaptation to aerobic training that we see in everyone, in healthy, in clinical populations. And it's really exciting that we're seeing this adaptation in these boys. Also, with that cardiopulmonary exercise testing, as I was showing you, this is an example in one boy. We're seeing increases in peak work capacity, peak aerobic capacity, and again, we're seeing these normalizations of heart rate, of ventilation going down, being more appropriate for the workload, and an increase in oxygen pulse. We're seeing improvements in time to exhaustion, so they're able to now cycle longer on that test, which corresponds with these increases in peak work. We've got a lot of other data that I won't have time to get into. We're not seeing any increases in serum CK, so this cycling exercise is safe. We're interestingly seeing some increases in bone density, which is interesting because most of these boys are on daily steroids. And really quickly, we're doing MR outcomes to understand what's happening at the level of the muscle and the muscle pathology. We're seeing, again, no increase in inflammation as measured by this transverse relaxation time. And In terms of the fat accumulation that we know occurs, in some boys we had really no accumulation. Some boys had a typical amount, about 5% that we would expect to see in 6 months of time because of disease progression. And then we had 2 boys that had a reduction in fat fraction. So again, these are very preliminary data. We need to extend this study to other patients, which we're hoping to get funding for, right, Tina? And we're also seeing improvements in phosphocreatine recovery time, suggesting that we are improving mitochondrial function. Okay, I'm going to finish on this note that the contraption that we built for exercise was really great in terms of proof of principle. We know that they can do a certain amount of work. But in terms of feasibility and moving forward with doing the study on a wider scale, we had to rethink things, and we had a very serendipitous occasion. So this boy, Noah, he started the training protocol, and that exercise bike broke. And so we had to send it back to UF, and now we were concerned because now he's going to lose some of the gains that he was working so hard for. And his mom said, well, I have this tricycle in the garage. So he took the tricycle out. It's made by Riften, put it on a stand. He's wearing his heart rate monitor. And here he is, cycling away in his prescribed exercise training zone. This is not assisted cycling. He's actually cycling on his own. But when we first started on this, he could only do 2 to 3 minutes of this, and then he had to stop because his heart rate was too high, and he was fatigued.
Remember, you don't have to go as fast as you
As
can
we
go.
continued the training over a month to 2 months, what happened was that became too easy. Now his heart rate was too low. It was not in his training zone. So now he took the tricycle on the road. And what happens? You have now friction, and so that made that bicycle, the triking, harder. Now his heart rate was in the zone. And here he is, and I just have to show you this because this just warms my heart that he's, out in his community cycling and, having a great time, and he's working out. And I just got to show you this part. A whole new world. I mean, this is his mom taking the video, not me. And so now this tricycle is great too because they just came out with a new model that actually has a resistance lever. So when this becomes too easy, we can actually also increase the resistance, and that's what we've done with him. Today, he's still cycling. He finished our 6-month trial, and Mom said, well, we can't just stop. And so we have him in an extension study, and he's now doing 30 minutes at resistance level 3 or 4. And he started off with just doing 2 minutes. So clearly we can improve their exercise capacity. Okay, final slides, I promise. I just thought this was really interesting, the whole SMA question about their reduced or their inability to really respond the same as other neuromuscular disorders. So last night I went through many of the studies that have assessed neuromuscular disorders. A lot of the dystrophies, the DMD is data from our study, primary mitochondrial myopathy, the 2 SMA studies that have reported VO2, and CMT. And here, this dotted line again represents this aerobic capacity that is really the predictive capacity for morbidity and mortality, and that's 17.5 mils per kg per minute. And you can see here, interestingly, that DMD, mitochondrial myopathies, and SMAs are below that level. But what we see is if we train these boys or these patients for 12 weeks, we can increase that aerobic capacity. We can change that VO2 virtually in all of them, but again, we're still seeing this blunted response in SMA and CMT. So why is that? That's what is the major question. But the good news is for the other neuromuscular disorders that they can really respond. And I'm going to skip that summary and just finish with thanking you for your patience. And I know I went really over time, but thank you. I'll take questions.
Okay, that was excellent, and we allow you to have the extra minutes because it was fantastic. Thank you so much. So we'll open that to questions here from the audience.
So I know you mentioned it looked safe with like the creatinine and everything. Were there any effects, like especially with him cycling for 30 minutes, like wiped out for the rest of the day or still functional for the rest of the day?
We talked to Mom all the time, and they're really, I mean, some days he might be a little bit more tired than others, but it's not like consistently that he experiences fatigue during the day because of the cycling. And actually, I didn't say it, but we do give them the PEDS Quality of Life Multidimensional Fatigue Scale, and they detect improvements in fatigue, but again, the fatigue they report at baseline before training is really not that severe. Yeah.
Second question is, if they don't have access to like adapted trike or the cycle, is this something you think they could do just propelling their manual wheelchair? Like, do you think it applies to basically any aerobic exercise?
That's a great question. I mean, we're coming at this more in an exercise physiology perspective. So we're monitoring their heart rate. We want them to train in a certain zone to get adaptations. But if we're just thinking about movement, mobility, blood flow, I think that, that's a great idea to try to do that. But really, we need to get these tricycles, for example, more accessible to the boys. And we're working on that.
Thank you.
Hi, that was really amazing. Again, just trying to tweak anything to help with fatigue in our patients. One of the questions I've always had is for our Duchenne men is that, we know that enalapril ACE inhibitors are cardioprotective. And cardiologists kind of have their different practice flavors as whether they start with a beta blocker or they start with an ACE inhibitor. And based on your data with the heart rate, I usually think of beta blockers as causing fatigue, but would that kind of modulation of the resting tachycardia actually help with their exercise tolerance? I wanted to get your thoughts about beta blockers. Would you, from your perspective, have any preference one way or the other? And then secondarily, metabolically, would that change the recruitment to the capillary beds, to the muscles to help improve that flatness of the oxygen extraction?
In SMA? The flat, yeah.
Both, but mostly Duchenne.
So in Duchenne, so all of these boys were younger. They were age 6 through 9, and none of them were on beta blockers or really cardiac meds yet. But that is a great question and concern if we're now wanting to train older boys. Having said that, patients with beta blockers exercise training, it's fine. Certainly you would expect that to maybe modulate or lower the heart rate some, but it'll still increase. It just won't go as high as it would without it. So how we modulate exercise training, that's standard for cardiac populations, for example. So I think that's doable. And the exercise extraction question, really hasn't been assessed at the level like using NIRS. I think Tina's doing it actually in DMD, but I suspect they do have an impairment in the extraction. And was the question whether beta blockers or cardiac meds would impact that? Yeah, I don't know. Again, we have to also keep in mind that they have a vasodilatory impairment in DMD because of the lack of neuronal nitric oxide synthase. So they do have a blood flow impairment, and actually we're starting a clinical trial next year where we're giving them vasodilator drugs combined with exercise, this tricycle exercise, to see if that will augment the training responses that we're seeing.
There's a few more questions from the online group. You aren't worried about damaging muscle fibers with training in DMD, and this comes down to what exercise are okay in DMD, right?
Of course. I mean, that's exactly what we're trying to show and advance the notion that appropriate types of exercise are safe and effective. We know eccentric, high-intensity exercise should be avoided because you're causing muscles to stretch or lengthen when they're being activated. But certainly, I think we're showing that cycle training is safe. My colleague Donovan Lott has done a study using isometric strengthening. So the muscle length is not changing, but it's producing force, and showed that 12 weeks of isometric training at 40 to 50% of their maximal voluntary contraction led to improvements in strength and also improvements in like the time to go up and down stairs. And there was no evidence of damage assessed by CK or MRI. So certainly exercise is beneficial, but it has to be appropriate.
Another question regarding to nutrition. Do nutritional dietary changes affect measured mitochondrial function in exercise?
Yes, so that's why you have to standardize the time of the cardiopulmonary exercise testing typically we do it at a certain same time all the time. So it's a great question, but yes, it'll change some of the metabolic parameters.
Yeah, in a way related, another question, how do you assure or standardize effort when measuring oxygen utilization or other measures of mitochondrial function?
So I'm not sure what they mean by effort. I mean, they cycle until they can't cycle anymore. And they poop out. So we have a very standardized protocol, and we make all those measurements from rest to that peak exercise. And actually now we're doing it beyond. We're looking at the recovery kinetics with Tina and some of her colleagues here as well.
Is there any particular time, that's my question, but is there any particular time of the day? We know that when we do clinical trials, we wanted to maintain some sort of, same quality and some time of the day, so then we assure that the patient is somewhat in the same.
Typically do it about 2 to 3 hours after breakfast, just because it's not fair to ask them not to eat and then do that. So.
And then we have one more. What are some key points or guidelines you use in treatment based on what you know now about fatigue, whether perceived or actual physical?
I don't know the answer to that. Or maybe I'm just...
Guidelines for exercise?
Yeah, the fatigue aspect did not affect or impede the training in the DMD boys at all. But I haven't worked with SMA patients, but I really have learned a lot now that is a problem with SMA. And, I think exercise training is still really important in that patient population. And I think the question is how to tailor the exercise to mediate that fatigue. But answer.
So one more. You have so many questions here. Looking at the profound differences in various measures of oxygen utilization and function in DMD, is it surprising that the 6-minute walk show no measured fatigue? Does it question effort in 6-minute walk or just a difference in the level of disability of patients in the different studies?
Yeah, that's a great question too. I mean, I don't know. The 6-minute walk test, I just, we see it. I mean, we definitely don't see that fatigue happening. And I don't know if the boys are pacing themselves because they know. And I'm not very expert at the 6-minute walk.
Kind of the problem why we don't encourage the 6-minute walk test is not showing that. And I mean, even the data about fatigability in the 6-minute walk test, why it's not the same as SMA, because the boys with Duchenne really respond in a similar fashion as controls, where, you get excited, your first minute or two, it goes up similar to controls, and then it's still the same. But when you see I think the difference that we're lacking in the Duchenne literature is the transitional 6-minute walk. The boys who are about to lose ambulation, it'll be nice to see the correlation between 10-meter walk velocity and 6-minute walk test, because if you dig into that group, we may see the fatigue. Because clinically speaking, we see that. But the stronger boys, we're not seeing that, so.
Yeah.
For our patients. So my name is Bar Bartels. I'm a pediatric physical therapist and a senior researcher and head of the Child Development and Exercise Center at the Netherlands SMA Center at the University Medical Center of Utrecht. And today I'm going to talk about fatigability, of course, especially about the assessment, mostly about SMA, and I'm going to touch on other diseases once in a while. So as the other presenters already discussed, is that it's very important to know the difference between perceptions of fatigue and fatigability. And today I'm mostly going to talk about is how the patient performs, so about performance fatigability, which is the inability to continue exercise at the same intensity, and is normally assessed with performance measures. So a very important paper from 2010 by our colleague Dr. Jacqueline Montes, in which I think she was probably one of the first to quantify fatigability in SMA, and followed by a study by one of my colleagues from the Netherlands SMA Center, in which she showed there's fatigability in SMA, but there's also variability between subtypes. So she studied the repeated 9-hole peg test in SMA in different subtypes, and she demonstrated that with this assessment, she was able to capture fatigability in SMA type 2 patients and in some type 3A patients, but it was mostly sensitive in SMA type 2. So what it shows is that fatigability is a big issue, but it really depends on the activities they perform. We asked in the past to children, what are the daily life activities that provoke fatigability? And we were quite impressed by all the different activities they mentioned. Both activities that ask proximal function, ambulatory function, but also distal function, like carrying a bag, using scissors, repeatedly throwing a ball above the head, lifting a glass to drink, and writing. And a similar pattern we saw in the adults. Again, a lot of different activities with a high prevalence of fatigability in daily life. So since we at that time didn't have endurance tests that would cover the whole spectrum of SMA, we started the development of the endurance shuttle test. And on forehand, we stated a number of criteria. So first of all, it should mimic daily life activities, and especially repetitive tasks. It should measure endurance. It should be tailored to the capability of a patient. And preferably, it would also include one methodology for all patients, for both ambulatory and non-ambulatory patients. We were targeting at a fixed intensity at submaximal capacity, and a very important, an external regulation of pace, like a beep test, to avoid that patient would be able to circumvent fatigability. And we stated that it should be a maximal test duration of 20 minutes. And it seems rather a long duration, but if you want to measure endurance, it has to take a while. It has to be a real endurance test. So the next step was to determine several activities for our tests. And for leg function, we selected walking, of course, and ended up with the outcome measure, the endurance shuttle walk test. For proximal arm function, we heard a lot from patients that lifting and transporting objects were very difficult, and we selected the box and block test. And for hand function, the 9-hole peg test. So we used already existing motor tasks, and we used one methodology based on endurance shuttle walk test to develop an endurance test and assess fatigability in SMA. In summary, patients had to walk, move bags, or transport blocks at a submaximal intensity over a maximal test duration of 20 minutes. They would drop out when too late twice in succession before the beep, similar to the endurance shuttle walk test. And for each test, we selected 2 primary outcome measures, the time to limitation and whether patients were able to complete 20 minutes. So there were a couple of interesting things that we learned from these studies. First of all, we studied the correlation between perceived fatigue and the endurance outcome in about 80 patients, both children and adults. And what you might expect is that perceived fatigue would be correlated to endurance. But what we saw in our population is that was not the case. So high endurance was not always combined with high levels of perceived fatigue and vice versa. So we had a lot of patients, they had low levels of endurance, but also low levels of perceived fatigue. And the interesting thing is that in our cohort, almost everybody fell within the reference values of available for the patient, the promised fatigue. So we didn't have a cohort that experienced a lot of perceived fatigue, but they did experience a lot of fatigability. And a similar pattern we saw with regards to strength. So perhaps you would think that patients with that are very weak would also experience the lowest level of endurance, so they would be in the quadrant C. And as you can see, there are quite a lot of patients. They are both weak and fatigable. But we also saw quite some patients in quadrant A and quadrant D, patients with low levels of strength and high endurance, and low levels of endurance and higher levels of strength. So it demonstrates that endurance and strength are not the same in SMA. And similar pattern regarding motor function. So yes, we did see a large subgroup of patients with low levels of motor function, measured with the Hammersmith, and low levels with endurance, but also a lot of patients that were in quadrant B, quadrant A or quadrant D. High levels of endurance, low levels of motor function, and vice versa. So the next step we took was to determine if we could compare patients from different severities, especially in a patient group like SMA, a heterogeneous group of patients in a rare disease. It's often very difficult to reach your sample size in clinical trials because patients differ in severity. So what we did is, first of all, we determined the highest individual level of motor function, whether it was ambulatory or non-ambulatory proximal arm function, or non-ambulatory with only distal arm function. The second step was to assess the most relevant endurance shuttle test. So of course, for ambulatory patients, the endurance shuttle walk test. For patients non-ambulatory with proximal arm function, the box and block test. And for non-ambulatory patients with only distal arm function, the Nine-Pack test. We performed the test in our patients and selected the same outcome parameter for each individual test, time to limitation and test completion. And what you see if you combine these tests, it really increases sensitivity and our sample size. So in our cohort, we were able to assess 15 endurance shuttle walk tests, 37 box and block tests, and 55 Nine-Pack tests. And if we took the most appropriate test for each patient, we ended up with 61 patients on this combined score, reaching a dropout of 85%. So 85% of our patients demonstrated fatigability on our endurance shuttle test. So the next question we asked ourselves, is fatigability typical for SMA, or do other patient groups also experience a similar level of fatigue? And the interesting thing is that we compared SMA patients with muscular dystrophy. Because of sample sizes, we were only able to do this on the Nine-Pack test. And as you can see, we compared SMA with a cohort of 15 patients with limb-girdle Becker muscular dystrophy and Duchenne muscular dystrophy with a similar level of muscle weakness. So they were similar on muscle weakness, but they were not similar in fatigability. This is a figure. It shows on the y-axis the probability of dropout on our endurance test, and on the x-axis the time since test initiation, or your time to limitation. And as you can see, that our SMA patients, about 60% dropped out, while our disease controls only 10%. So the fatigability that was really striking in SMA on our endurance shuttle Nine-Pack test, we did not see this in muscular dystrophy patients with similar weakness. And this is also, this has been reported before by our colleague Jackie Montes, and showing that there was a correlation between fatigability and the 6-minute walk distance in SMA, but not in Duchenne and Becker, in myasthenic gravis, treated patients, or in mitochondrial disease. So the next question we asked ourselves, and with us a lot of people working in SMA, is this problem of fatigability really we really recognize this problem in myasthenic syndrome, in which neuromuscular junction dysfunction is a very important cause. And we did know from studies both in animal studies and in ex vivo, is that there are abnormalities in neuromuscular junction function and in the anatomy. So there were abnormalities reported in the development and the maturation, and those abnormalities were both pre and post-synaptic. In 2012, one of our colleagues from the Netherlands SMA Center, she reported in a study on EMG and doing repetitive nerve stimulation in both SMA patients and controls. And what she found is that in 50% of patients with SMA types 2 and 3A, there was a decrement of more than 10% on repetitive nerve stimulation, which indicates there's a neuromuscular junction dysfunction. And these abnormalities were mostly seen in the accessory nerve, so in the shoulder muscles. So we hypothesized that pyridostigmine could be a potential treatment for patients with SMA. And this drug is already used in standard treatment for myasthenic syndrome. So it takes a bit, we don't have a lot of time to discuss the mechanism, but eventually it will improve neuromuscular transmission by inhibiting acetylcholecystase and improving the acetylcholine. So we performed a monocenter clinical trial in SMA in 35 Dutch children and adults with SMA types 2, 3, and 4. And we performed a crossover trial with 8 weeks of pyridostigmine, followed by 8 weeks of placebo. And what we found is that 74% improved on patient-reported endurance. So we asked patients if they felt improvement during daily life activities, both during the pyridostigmine arm and in the placebo. And we found a significant increase in patient-reported outcome. It was safe and well tolerated. And very importantly, we also demonstrated a 70% reduced risk of dropout on our endurance test. So in the treated arm, there was a large improvement in endurance on our endurance tests. And interestingly, during this trial, we also assessed surface EMG. And what we found is that there was an enhanced low threshold motor unit capacity in patients treated with pyridostigmine. So we didn't find an increase in strength measured with handheld myometry. We didn't find a lot of difference in amplitude, but we did a reduced decreasing slope in frequency. And it was really interesting that these were signs that this drug might specifically target the low threshold motor units. So we did find that neuromuscular junction function and better neuromuscular junction function would improve endurance. But what about metabolic dysfunction? Could it also be a cause of fatigability in SMA? And as Tanya and Sally mentioned before, there have been studies taken muscle biopsies on signs of mitochondrial dysfunction. So what we did is an in vivo dynamic exercise study using 31-phosphor magnetic resonance spectroscopy to measure oxidative metabolic function in SMA. And as Tanya mentioned before, is that recovery time of PCR depletion can be an indicator of mitochondrial abnormalities. So we hypothesized that the recovery time in SMA would be longer in healthy controls, perhaps reflecting mitochondrial abnormalities. So PCR, you can imagine that it's kind of a battery, and it's a full battery when you start. Then it's depleted during exercise, and then after exercise there's recovery, and you will upload your battery, and the speed in which this recovers tells you something about mitochondrial function. So there were a couple of interesting things we found in this study. It was published in not a very long time ago, in 22, in Brain, from one of our colleagues. And first of all is that we found a fiber type shift in SMA. So with a dominance of oxidative red fibers. And it's a very nice method in which you are able to differentiate between fibers based on inorganic phosphate peaks on different pH levels. And what we found in SMA is that there's a dominance of oxidative fibers in comparison to healthy controls. And the other thing what we found is that is a delayed recovery in white fibers. So in the non-oxidative fast twitch fibers, there was a delayed recovery after exercise. And that is something we did not find in oxidative fibers. So there seems to be especially a problem with fast twitch non-oxidative white fibers. And it is something we expected based on literature and the fact that patients experience muscle weakness. But this was the first time that we also were able to objectify this in vivo during exercise. So we did find normal mitochondrial function in oxidative fibers, but a lower oxidative capacity in fast glycolytic fibers. And we think this is a potential biomarker for clinical trials and natural history. So in addition to the MR measurements, we also assessed motor unit and capillary recruitment during arm cycling exercise in SMA, using a surface EMG, NIRS, and looking at oxygen consumption. And we, in our cohort, we did not find evidence for the contribution of motor unit and capillary recruitment capacity of the upper arm muscles in adolescents and adults, patients with SMA types 3 and 4, as primary limiting factors to premature fatiguing during execution of a maximal arm cycling task. So first, the cardiopulmonary response, as you can see in the 4 figures, is that SMA patients, if you adjust oxygen uptake for lean body mass, we found similar patterns compared to controls, both for VCO2, VO2, ventilation, and RER. So this was quite surprising, actually. Of course, we did find a higher ventilation and also a higher oxygen uptake adjusted for peak workload. One of the hypotheses is that they use a lot of more muscles to do their exercise. So when they were cycling with their arms, they were moving all their body to keep on going. And using NIRS, which I still find a very complex tool to evaluate blood flow and oxygen consumption, we did not find a very significant limitation in capillary recruitment. So blood flow was not very different. Slopes in blood flow were not very different from healthy controls. Also another quite interesting result was we didn't find a very limitation in motor unit recruitment. So our slopes in amplitude and frequency were not different from healthy controls during this exercise. So this part is mostly about fatigability using your arms and your legs. But what about respiratory muscle fatigability? And we all know that respiratory function and respiratory muscle strength are very important for SMA, and that it declines over time in all subtypes, both in type 1, 2, and 3. So do patients experience the same level of fatigability of their respiratory muscles as they do in their arms and their legs? So Kim Kant-Smith, one of our PhD students, she published in 2022 a study on respiratory muscle fatigability in SMA. We included 55 patients, types 2 and 3, and age 8 to 59, and we asked them to breathe 60 breaths on either 20%, 35%, 45%, 55%, or 70% of their maximal inspiratory pressure. And what we expected that fatigability of the respiratory muscles would be similar or even worse than in Duchenne muscular dystrophy. This is already some older study in 2000 by Matecki et al. And they studied respiratory muscle fatigue with a protocol in which patients had to breathe against 35% of their maximal inspiratory pressure. And as you can see in the table, that patients with DMD were able to continue for between 2 and 6 minutes with a mean endurance time of 4 or 5 minutes, while healthy controls were able to continue for at least 30 minutes, and then they stopped the test. So there's an increased respiratory muscle fatigue in Duchenne muscular dystrophy. And because of the complaints from SMA patients, we expected that would be even worse in SMA. But on the contrary, it didn't happen. So we found that the cutoff point for respiratory muscle fatigue in SMA was around 55% of their maximal inspiratory pressure, which is comparable to normal reference values. So the fatigability we see in their arms and their legs is not present in their the respiratory muscles. And one of the explanations we think of is that the diaphragm, which is a very important inspiratory muscle, is relatively spared in SMA, in contrast to patients with Duchenne muscular dystrophy. So in summary, fatigability is a highly prevalent and additional dimension of physical impairment in patients with SMA that requires attention and treatment. The endurance shuttle test combined score allows comparison of patients with varying severity on their individual most relevant endurance test, thereby increasing sensitivity and statistical power. So we have a test we can use for heterogeneous sample of patients. And fatigability is associated but not equivalent to muscle weakness in SMA. Pyridostigmine has important value as a treatment for fatigability in children and adults with SMA. We treat now over 60 patients with SMA with pyridostigmine, and they really tell us that it improves their fatigability significantly in daily life. Fast glycolytic muscle fibers in SMA seem to be vulnerable to fiber type shift and delayed recovery after exercise. And the patients with SMA types 2 and 3A demonstrate adequate inspiratory muscle endurance, which makes it possible in the future to look at the efficacy of inspiratory muscle training. I would like to thank all patients that are involved in our studies and are treated in our center, my colleagues from the Netherlands SMA Center in Utrecht, and I'm happy to answer any questions if there are there. Thank you.
Thank you so much. That was excellent, excellent review. Are there any questions from the audience? Otherwise, I can just go over like the ones online. I will start with that. I will start with my own question. What is the dose of the pyridostigmine that you use for those patients?
That is a very good question. I think, so I don't know that exactly. Our paper is published. And yeah, we can look it up very easily. I don't know this now by mind how much the doses was, but it's
Okay.
easily to look it up.
Okay, thank you so much. We will. Is there any difference, if you're aware, between nusinersen and risdiplam effects on fatigue in SMA? And is there any effect of albuterol?
Yeah, that's a good question. So I think there are some studies that report on endurance in these trials, but there's not a lot of evidence so far. We are currently assessing our endurance shuttle test in patients that are treated with these disease-modifying treatments as part of both clinical care and conditional reimbursement trajectories. From my experience, it seems that pyridostigmine is very effective to improve fatigability. I don't have heard the same experiences yet regarding disease-modifying treatment. Albuterol, we don't treat any patients, I think, with albuterol in our center. So I don't have experience with that treatment.
Okay, thank you so much. Another question regarding fatigue with riding. Some patients commonly complain about fatigue with riding. Is it possible to quantify how well or how long patients can perform some standardized riding?
Yeah, that's a good question. So of course you can ask patients to ride longer for a longer while and look at for example, and how if the quality deteriorates. I'm not aware of any like formal test. So we decided to use the endurance shuttle 9L peg test because this was also already a test that was validated for other patient groups, and of course it's not the same motor task. What we did learn from our patients is that if they would improve on a test like the endurance shuttle 9L peg test, the feeling was the same when doing other fine motor tasks. So I think that if a patient significantly improves on endurance shuttle 9L peg test, there's a big chance they also improve in other fine motor tasks like writing, but we have never compared these two tasks.
Okay, thank you so much. Yep, there's one more question.
Hi, Bart. This is Tanya Tavasalo. Really nice talk. I just had a question on your thoughts about the fiber type shift towards a slow profile, and why is that? And I guess, does that account for some of the aerobic training responses that we've seen with the higher intensity? And what would you recommend for exercise?
Yeah, so it's a really good question, and the really short answer is that on the first question is I don't know. I think there's a lot of so there are more studies that indicate that larger motor neurons are more vulnerable to SMN depletion than smaller motor units. So it wasn't, and we also see that especially weakness is of course really a problem. So we were not surprised that the FG fibers were very vulnerable, but we were surprised by the fact that the oxidative fibers they seem to work properly. So at least if you look at mitochondrial function, the thing that we learned from our from our space trial on pyridostigmine that it seemed that they, of course, we don't know this for sure, but it seems that it primarily targets neuromuscular junction of smaller fibers, because we did not see any increase in strength, but we did see an increase in endurance, what was also reflected in our surface EMG. Concerning your second question, I think that if you train patients, non-treated patients, I think there's a really potential in aerobic training, because we also, of course, patients are more sedentary than healthy persons. But with the DMT, the disease-modifying treatment, but also in combinatory therapies with, for example, the inhibition of myostatin, I think there's a window of targeting the larger fibers with high intensity training, and that was also already shown in animal studies with SMA that high intensity training was more effective to improve the function of larger motor units.
Thank you very much.